other neuromuscular junction-related disorders. I will also recognize the typical clinical history, presentation, and risk factors of myasthenia gravis and myasthenic crisis. I will also outline acute management priorities. I will describe monitoring strategies for respiratory function and indications for intubation. And lastly, we'll identify indications for transfer to a higher level of care. So the didactic presenter for today is none other than Dr. Mutale Mulenga, and we've been privileged to be joined by a panel of experts which constitutes Dr. Melody Asukile, Dr. Stanley Zimba, and Dr. Chilando Mulenga. So before I can invite the didactic presenter to go ahead with this presentation, I'd just like to once again remind us of our housekeeping rules. The first one being that you are all encouraged to have your microphones muted at all times to ensure that there's a smooth flow in the conversation or in the presentation by the didactic presenter. And also, you're encouraged to engage through the chat box to ask any questions, as well as by show of hands, and you have the opportunity to speak through the facilitator, who is myself. So without further ado, I will allow Dr. Mutale Mulenga to go ahead with his didactic session. Thank you very much.
Good afternoon once more. Thank you so much, Dr. Mkambo, for that introduction, and welcome everyone to today's presentation. I welcome all our panel of experts and all the senior colleagues on the call. So welcome to today's topic. So basically, we're going to dive deep into neuromuscular disorders, in particular myasthenia gravis, as our topic of discussion today. So I have no disclosures. So these are our learning objectives for today. So we're going to explain the pathophysiology of myasthenia gravis, recognize the clinical features of myasthenia gravis, choose appropriate investigations, and we're also going to describe the current treatment options, and then also identify and manage myasthenic crisis, and also look at other special considerations such as myasthenia gravis in pregnancy as well. But before we dive deep into our topic, we're going to have a poll.
Okay, so you'll see a poll pop up on your screen in a few seconds. Also, you're all encouraged to interact. And the poll reads as follows. Have you managed a patient with myasthenia gravis? Which antibody do you request first? So the first one we have is AChR, we have MuSK, we have IRP4, and then the last is I request all antibodies. So you can go ahead and answer. I've seen that we have a response rate of 31%, 42% have answered. Okay, we can keep the answers coming. So this is anonymous. We won't know which individuals have answered with which responses. So feel free to answer. Okay. So I'll just give it maybe 10 more seconds to allow others who haven't responded yet to do so. Okay, I'll go ahead and end the poll at this point. Yeah. So these are the results of the poll. And we'll proceed to the second poll. Do you want to speak, please? Or? Yeah. Not to the data as well. Yeah. And the second poll is on your screens. So the second poll reads as follows. Which investigation is most useful if antibodies tests are negative? A, MRI brain, B, repetitive nerve stimulation, C, single fiber EMG, D, EEG. Okay. I've seen responses are coming in. We are at 36%. You can continue responding. We still have a bit more time. Okay, we're standing at 58%. Those that haven't responded, please do so. Okay, I'll close the poll in 5, 4, 3, 2, 1. Okay, thank you very much, everyone. And those are the results of the poll. So I'll hand over back to Dr. Mtalemnenga to proceed with this presentation.
So thank you so much, Dr. Emmanuel. So those two questions basically just highlight some of the dilemmas we face as clinicians whenever we are encountered with such conditions. And I think we'll come back to this poll later on, and then as we dive deep into the topic. Okay. So what is myasthenia gravis? So basically, it is an autoimmune disease. It affects the neuromuscular junction. We're going to understand further what we mean by neuromuscular junction further. So this now causes muscle weakness that becomes worse with activity. So that's a very important point to remember, that it gets worse with activity and it improves after rest. Okay. And usually does not affect any sensation or reflexes. So your sensory functions will, in fact, will just be fine. So the key message to take home just from this definition or simplified definition is that you have to think of myasthenia gravis as whenever someone's weakness becomes worse as the day goes on. So probably they woke up just fine, and then as the day goes on, they start having that weakness, as we're going to understand further. Okay, so I need with that teacher. All right. So this is basically a graph or trying to understand the neuromuscular junction and the physiology behind myasthenia gravis. So basically, what you see on your right, basically what you see on your right is a graphic representation of this is supposed to be a nerve, and this is supposed to be the neuromuscular junction here. And this is the muscle. So input comes from the nerve. So what you want is that the input's supposed to come through the nerve, all right? And then this message is transmitted through the neuromuscular junction. This is what we mean by the neuromuscular junction. And then this muscle here gets to contract or do what it's intended to be. So normally what you have is you have, when an input comes through this nerve, you have acetylcholine as acetylcholine is going to be released into the neuromuscular junction. So this gets to bind to these receptors here, okay? And when it binds to these receptors here, this is what now causes that message or that input that is coming through, causing the muscles to contract, right? So if we go back to our slides here, we're saying when this input comes, acetylcholine has to be released, and then acetylcholine has to now bind to acetylcholine receptors on the muscles here, which causes sodium now to enter, causing depolarization, and then muscle contracts as well. Okay. So after all this happens, there's an enzyme called acetylcholinesterase, right, that comes now to come and mop up the excess acetylcholine that has remained at the neuromuscular junction here. Right. So now what happens with myasthenia gravis is that you have, if input comes the same way we described, acetylcholine is released here, but because of certain antibodies that have been released, they end up attacking the receptors at the muscular here, all right? The acetylcholine receptors will end up being attacked. So meaning that even if acetylcholine is released, it will have nowhere to attach, meaning sodium won't enter the muscles and there won't be any contractions. Okay, so that's basically what happens at the neuromuscular junction and brief pathophysiology of myasthenia gravis. Okay. So ideally, we have these autoantibodies that block or destroy the acetylcholine receptors, all right, at the postsynaptic nerve, and then we have less signal that reaches the muscle. Then the muscles eventually become weak because they're not contracting as much as they're supposed to contract. So why does this occur? So this occurs because the immune system mistakenly attacks the proteins at the neuromuscular junction. So when this attack comes, you have less receptors at the neuromuscular junction, leading to less acetylcholine, and then subsequently less contractions. Okay. So these are the main antibodies that are found. So we have acetylcholine receptor antibodies, right? And then we have mask antibodies as well, and LRP4 antibodies. We'll dive deeper into this when it comes to diagnosis of the condition. So the result from this is that these antibodies now cause fewer functioning receptors. Then there's going to be reduced safety factor of transmission, and then eventually the muscles will fail to contract, and then we'll have what we term as fatigable weakness. Basically, the more you use the muscle, the more it becomes weak, as there is less and less acetylcholine that is being taken up at the postsynaptic nerve endings. Okay. So this condition usually affects about 15 to 25 people per 100 people, and it has this bimodal age distribution. So we have women being affected before the age of 50, and then men usually are affected after the age of 50. But of course, with nowadays, the better diagnosis and treatment have increased survival as well. Okay. So the clinical pattern, so we have the typical general pattern where we have this weakness, which is fluctuating. So it becomes worse with repeated activity. And that's a very important point that you have to remember, is that the weakness is fluctuating, also called fatigable weakness. It comes worse with repeated activity. So someone just wakes up just fine. As the day goes on, they become unusually weak, all right? Or as they do some activities, right? So rest improves this weakness, okay? And then we have eye, facial, swallowing, speech, neck, and limb muscles that may be affected. Of note is that the sensation or sensory functions are going to be usually just normal, okay? And then we also going to have deep tendon reflexes that are going to be preserved. So the clinical, when you're seeing the patient, some leading questions that you can ask is, what can the patient do in the morning that becomes difficult later during the day? So for example, they woke up just fine. Maybe they become weak during the day. They start having difficulties even speaking or lifting the eyebrows as the day goes on, or just generally becomes weak, but they woke up just fine. So that's one way that you can try to tease out the answer from your patient. Okay. So in terms of the clinical classification, so we have ocular myasthenia gravis, basically predominantly affecting the eyes or the ocular system, and then generalized myasthenia gravis, which involves our bulbar muscles, the neck, and the limb muscles as well. So when we look at ocular myasthenia gravis, so this is in most patients, this is going to be the common first presentation. So they're going to present as ptosis, which often fluctuates during the day. So ptosis, basically, you find that the easiest way to explain it, that patients usually failing to completely open their eyes. And then this ptosis, it can be asymmetrical, it can be in one eye, it can be both sides, and it also can fluctuate between the eyes with varying intensity as well. And then you're going to have binocular diplopia, which is going to be due to the weakness of the extraocular muscles. And then these eye movements may appear inconsistent between examinations. So, and then pupils or your pupillary exam is going to be normal. So important differential is that in myasthenia gravis, your pupils are spare, right? So whenever you find an abnormal pupil, it should make you reconsider another diagnosis. So an examination tip to try and tease out some of these ocular findings is basically just ask the patient to look upwards continuously for about 30 to 60 seconds, and then you'll find that the ptosis will become more obvious as they approach the almost like 40, 50 seconds. Okay. When it comes to generalized myasthenia gravis, so the characteristic pattern is that it affects the proximal more than distal muscles, leading to weakness. So the weakness may involve the neck flexors. So this will manifest as them having difficulties just holding the head up. And then they have shoulder muscle weakness as well. So they'll have difficulties lifting their arms. They'll have hip muscles. So all these are proximal muscles that we are referring to. They'll have hip muscle weakness as well. They'll have difficulties climbing stairs or rising from a chair. And also it can affect respiratory muscles, which will lead to shortness of breath and a very weak cough. As earlier alluded to, sensations is going to be normal. Okay. So as part of generalized myasthenia, they will have bulbar and facial weakness as well. So the bulbar symptoms, so just dysarthria. So progressively, patients who have difficulty speaking and sometimes might even develop like a nasal speech. Then they'll have dysphagia. They are just difficult to swallow in, especially with solids. Difficulty chewing, or they become tired as they are chewing. The more they chew, or the more they use the muscles responsible for chewing, they become tired of chewing, especially with hard foods like meat. They'll have a weak cough, and also have like difficulty clearing some secretions, right? In terms of facial weakness, so they'll have reduced facial expression. They'll have difficulties closing their eyes, difficulty smiling, and then when they try to fill their cheeks with air, they'll have this difficulty pulling puffs. They easily pull out the puffs, pulling puffs out of the cheeks. Okay. So diagnosis is mainly clinical, right? And then which is going to be supported by testing. So you have to look for fluctuating fatigable weakness. So remember that ocular symptoms will be the first presenting symptom from some patients. So you have to look for ptosis and diplopia, bulbar symptoms, dysarthria, dysphagia, chewing difficulties. You have this proximal limb weakness as well with normal sensation. And then when you do your exam, you realize that your reflexes are going to be preserved. So once you have that clinical picture now, then you have to examine your patient. So there are simple bedside tests that you can use to try and test for the types of weakness or the weakness patterns that we have looked at. So some of them are just simple tests for fatigability will be sustained upward gaze. So you just ask the patient to look upwards. You can count even up to 30 to 40, 60 seconds, and you're going to observe increasing ptosis as they count. Then the other thing you can do is repeated counting. So just ask the patient to count out aloud, and then you have to listen for progressively a weaker or nasal speech as you're trying to assess for dysarthria. Okay. So you can also do a repeated arm elevation. So you ask the patient to hold both arms up, and then you just look for progressive weakness. So they just slowly start dropping their hands down as they proximal muscles become weak. You can also use an ice pack test. So you can just place a cold pack over a drooping eyelid, usually about 2 minutes, and then reassess for ptosis after 2 minutes. So improvement supports ocular myasthenia gravis. So when you place this ice pack for about 2 minutes, you find that the ptosis resolves or improves, and then this improves or supports your diagnosis. Other things you can do is and I think this is one of the most important tests you should always do, is a single breath count in institutions where you do not have a spirometry. So you can do a single breath count. You basically just ask the patient to inhale fully, and then you ask them to count as they are slowly breathing out, right? So a normal count is supposed to be anything between above 25 to 30. And if your patient is having anything less than 20, so that suggests significant respiratory muscle weakness. And now these will need spatial like ICU consideration. And this is now start to alarm you to say, I need to refer this patient if you do not have those services at your facility. And then anything less than 15, this is concerning for severe weakness. Usually you want this patient to even be intubated as well in ICU. Another test you can check for at bedside is the neck flexion. Right. So remember, they have this flexion weakness. Their head is always like bent down. So that's one way to also assess for diaphragmatic muscle weakness using neck flexion and extension. Okay. If you have at your facility, you can go as far as doing the forced vital capacity or the NIP, as we'll look at we'll look at that. Okay. So once you have your clinical suspicion, now you want to confirm your diagnosis, okay? And I think one of the polls was looking at which antibodies test are you going to do. Remember, these antibodies tests cost money and it's quite expensive. Not usually regularly done from government facilities, so you have to be specific in which antibodies you're going to request for. So about 80% of patients with generalized myasthenia gravis usually have acetylcholine receptor antibodies. So that is going to be your first line antibody that you're going to test for if you suspect a patient has generalized myasthenia gravis. And you find that it's positive in most generalized cases, about 80% of these cases. In the event that you find that it's negative, you can now consider masked antibody testing. All right. So, and then this is also, you should also consider it if you have prominent bowel and facial weakness as your presenting symptoms. Also, if they have severe neck and respiratory weakness as an initial presenting symptom. Okay. If both of those are negative, then you can now go down the line and consider doing the low density lipoprotein or the ALRP4 antibodies, which may help in patients who have, if they have got negative acetylcholinesterase antibodies and masked antibodies. Okay, so your chain of is going to be, you have a clinical suspicion, you've got clinical suspicion here, then you go and you check for the acetylcholinesterase antibodies. If it is negative, then if it is positive, rather, myasthenia gravis is likely. If it is negative, you go further to check for mask or ARP4. If these are still negative, then now you consider other supporting diagnoses such as repetitive nerve stimulation or single fiber EMG, and then CT chest to assess for thymomas as we'll look at later on. Okay, so electrophysiological testing, right? So when antibody tests are negative, but you still have a very strong clinical suspicion, and you want to basically support your diagnosis, then you can go further and do repetitive nerve stimulation. All right, so you stimulate the motor nerve repeatedly and look for decremental response. So a significant decrement supports like this your diagnosis of myasthenia gravis. You can also do a single fiber EMG, which is going to be the most sensitive test to support the diagnosis of myasthenia gravis, but also non-specific as it can also be positive in other neuromuscular junction disorders. Okay. So in terms of management, so you have to have your treatment goals or what you're trying to achieve when you're trying to manage these conditions. So we are trying to improve muscle strength and reduce daily symptoms. So basically symptomatic treatment. And then you're also trying to prevent what is called a myasthenic crisis and respiratory failure. Minimize treatment-related adverse effects. And then you want to achieve minimal symptom expression, what they call minimal symptom expression. And also treatment should be individualized according to the myasthenia gravis subtype and severity. So we have three pillars or three components of treatment. So basically symptomatic treatment, immunotherapy, and then thymus-directed treatment. So for the symptomatic treatment, your first line drug you're going to use is called pyridostigmine. So basically it inhibits acetylcholinesterase enzyme from mopping up the excess acetylcholine, which results into it being increased at the neuromuscular junction. So this is useful for mild symptoms and some patients who have ocular weakness. Of note that it does not treat the underlying autoimmune condition as it is not a disease-modifying drug. Okay. So immunotherapy, so when you give the symptomatic therapy and you find that it is not enough, your patients still having the same signs and symptoms, you now have to consider immunotherapy. But you have to be very careful when you are initiating patients on immunotherapy because these drugs we're going to look at next most of them cause immune suppression. So you have to make sure you test for conditions that check for your HIV, check for hepatitis B and C. And make sure that they have all the vaccines as well. before you initiate the patients on immunotherapy. So our first line is always going to start with corticosteroids. So you can use prednisolone, which is commonly used and readily available in our settings, which is effective for generalized myasthenia gravis. So one thing of note is that you have to start from a low dose, because at least 15%, if you start from a high dose, about 50% usually have effects of, they have worsening weakness when you start them on prednisolone. So you have to start at a very low dose and gradually escalate up. Okay. So usually you can start from as low as 15 milligrams to 20 milligrams per day, and then gradually increase. So we've noticed that improvement may take weeks, but early steroid treatment can occasionally cause temporary worsening, as we've said, but this is dependent on the dosage, especially if you start them on a very, very high dose. So remember, you want to start them at a low dose, at least 15 milligrams to 20 milligrams, and then escalate further. Then you realize that at roughly maybe for about 4 months of maximum steroids, and then your patient is still having symptoms, then now you can try to escalate further down and try to use other steroid-sparing agents. The other reason you want to also consider using steroid-sparing agents is that steroids come with a lot of side effects, and you want to try to minimize those side effects as well. So we want to also transition your patients to using steroid-sparing agents. So the examples we use, some examples and the most common ones that are available are azathioprine, mycophenolate, mofetil, tacrolimus, and cyclosporine. So azathioprine will be our first choice in this case, just because it's readily available, but it usually takes about 3 months for it to take effect. So usually during that period, your patients still need to be on that steroid as you are tapering down slowly. Okay. You can also use mycophenolate, but this also takes research evidence shows that it starts working at least after 6 months. So it has to be very long-term use. And then if you're considering, if you're a woman of childbearing age and you're considering being pregnant, you probably want to avoid mycophenolate as well. Tacrolimus and cyclosporine are also good drugs, but they also come with quite severe side effects, so you want to avoid them as well. So the goal here is to control myasthenia gravis while reducing the long-term steroid exposure. So remember, once you start the steroid-sparing drugs, you are supposed to also start tapering down on steroids. That's assuming that you had reached maximum dosage within the 4 months before you decided to switch. Okay. So we also have rapid immunotherapy, and the two major options that we use is IV immunoglobulin and plasma exchange. But these will be used only when you're having a myasthenic crisis, as we're going to see next. Okay. So thymectomy or thymus. So thymectomy is also part of management. So basically, the basic understanding here is that the thymus also plays an important role in an immune response. So it's very important for T cell maturation and immune tolerance as well. So if you have a hyperactive thymus or hyperplasia, you find you have a situation whereby you have the T cells will start overproducing, will activate the B cells, will start overproducing the acetylcholine esterase antibodies. Okay, so in this case, you would want to have it removed. But it's not every patient that is a good candidate to have these thymectomies. So you're going to have a thymectomy in a patient that has got a thymoma. In that case, the thymectomy is going to be indicated. And the other thing is a patient with generalized myasthenia gravis who has acetylcholinesterase antibody positive. Even if they don't have a thymoma, selected patients do benefit from a thymectomy, and usually young females that are usually good candidates. So that's the MGTX trial that looked at thymectomy plus prednisolone, and then in this trial they found that there was a reduction in myasthenia gravis disease severity, and then they reduced the prednisolone requirements, and then they reduced the need for rescue therapies as well. Once they did the thymectomy plus prednisolone as treatment. Okay. So myasthenic crisis. So this is basically a neurologic or emergency. So this is a severe form of myasthenia gravis, which is causing respiratory failure and impending respiratory failure. So the warning signs that we're going to look out for is you suspect someone has got myasthenia gravis, and then they're having increasingly shortness of breath, they're having a weak cough, difficulty swallowing, secretions, severe dysarthria, rapidly worsening neck weakness, unable to count adequately on one breath. Remember earlier when we talked about the single breath count that you can use as a proxy for severe respiratory, impending respiratory failure. So you do your single breath count, you find that below 20 or 15 to 20, that's impending respiratory failure, so they need to be nursed in ICU. So that qualifies as someone having a myasthenic crisis. So assessing respiratory function here is going to be very key. If you're in a facility that has got spirometry, you can do a forced vital capacity. Okay, and again, anything below 20 is considered danger signs, and this is a sign of impending respiratory failure. You can also do a negative inspiratory force, and what you're looking for is anything below 40 centimeter of water as well. Then look for respiratory rate and the work of breathing. Okay, so one thing of note is that pulse oximetry here does not work, or is a very bad indicator, because what you're looking for is respiratory muscle weakness, not oxygenation. Okay, so if you don't have a spirometer at your facility, you can easily use single breath count or just the rate of counting, as we mentioned earlier on when we looked at a simple bedside test that we can look at. Okay. So there are precipitants for myasthenic crisis. So what you're going to look for triggers. And the common precipitants in our settings include infections, surgery or major physiologic states, inadequate myasthenia gravis treatment, medications. We'll look further at medications in just a bit, pregnancy and postpartum period, or aspiration. So these are some of the drugs that we have to avoid in patients who have got myasthenia gravis, as they do worsen myasthenia gravis and precipitate your patients into going into a crisis. So they are everyday use drugs. Okay, so it's an extensive list, but I just picked out the common ones that we usually encounter in our settings. So antibiotics such as aminoglycosides, so our gentamicins of this world, will try at all means to avoid or use alternative options. Fluoroquinolones, the ciprofloxacillins that we use, macrolides such as the erythromycin, azithromycin, we'll try as much as possible to avoid those drugs. IV magnesium in our obs and gyn patients, some beta blockers, and then your muscular blocking agents such as Botox as well. So these are the common ones that you would want at least to avoid and use alternative options for them. So a typical example is someone who has myasthenia gravis. Maybe as a clinician, you didn't take a very good history, comes in with a cough, you try and give them one of these antibiotics, and then they get worsening respiratory symptoms, and they go into a crisis. That will how this is going to present. Okay. So the practical rule is that before prescribing a new medication to a patient with myasthenia gravis, you have to check whether it can impair the neuromuscular junction. So like I said, it's an extensive list, but you can easily quickly look at it, see what type of medication you want to prescribe for your patients, and also look for alternatives that you can offer your patients. So for the treatment of myasthenic crisis, so you're going to do rapid immunotherapy, and you want to do plasma exchange as soon as possible. Okay. So remember that in this phase, in a myasthenic crisis, you're not going to use the symptomatic treatment with pyridostigmine that we had prescribed our patients who had mild to moderate myasthenia gravis. So during this severe crisis, you withhold the pyridostigmine especially in patients that are intubated and they're having excessive patients, because one of the side effects of polydistigmine is that it causes these cholinergic effects, right? And then this can complicate the airway as well. But it can be restarted after your patient improves. Okay. So special mention to a pregnant population is that pregnancy requires careful monitoring and planning and close monitoring as well. So the disease course is unpredictable. So they say there's a third of each. So a third of the patient might improve due to the pregnancy, a third of the patient remains stable, and a third of patients might worsen. Okay. And exacerbations are particularly important during in the early pregnancy or in the postpartum period. So you want to continue effective treatment, which is polydestigmine and the immunotherapy. In this case, we use the corticosteroids, which are most commonly used. So IVIG or plasma exchange can be used for severe exacerbation or crisis, as earlier explained. Then you want to avoid some of the immunotherapies, such as mycophenolate, methotrexate, and cyclophosphamide, as they are teratogenic as well. So when it comes to delivery, myasthenia gravis alone is not an indication for cesarean section. So basically, normal delivery is warranted for them as well. And then there is something called neonatal myasthenia gravis. Okay, so the maternal IVIG antibodies, they do cross the placenta and can cause a transient neonatal weakness, which manifests as feeding difficulty or have a child having respiratory problems. But this is transient because these are just the maternal IVIG antibodies, which tend to fade over time. Okay. So summary of our key points or our take-home message is that we need to be able to recognize the pattern. We need to confirm the diagnosis systematically, okay, and make sure we look out for respiratory functions, treat according to severity, and recognize the crisis early. Okay. So these were my references, and thank you so much for your attention.
Okay. Thank you so much for that great presentation, Dr. Mlenga. And so I've noticed that we have a few questions, so I'll just go ahead and read them out. And this automatically leads us into the comments and comments and any add-ons from the panel of experts. So throwing the first question to the panel of experts, this is coming from Evelyn Shamenda, and it reads as follows. What's the difference between MG and GBS? What's the difference between myasthenia gravis and Guillain-Barré syndrome? I don't know if any of the panel of experts would like to take that up.
Everyone, yeah. Thank you so much for the talk. That was, a really comprehensive talk. Thanks to Dr. Mtale. I think a few comments before we go into the discussion. One thing that's very important, as Dr. Mtale highlighted, is the clinical diagnosis of myasthenia. And that's why we're having the discussion today. So it's very important for us to be able to make the diagnosis clinically. And myasthenia gravis is one of those things where indeed we have the tests, like we have the antibodies, we have the nerve conduction and EMG, but like many conditions, those support the diagnosis. Because sometimes you can have all the antibodies negative. Sometimes the nerve conduction study will really be dependent if you can get it. Right now, we only have 1 or 2 places in Zambia where the test is done. So that shouldn't discourage us from making the diagnosis. If you can make the diagnosis clinically and you've excluded other things, then it becomes warranted that you can treat this patient as myasthenia. So now to make the clinical diagnosis, it comes to that first question. For example, someone said, how do we differentiate from GBS? So in neurology, and what we try to emphasize throughout is before you make a diagnosis, it starts with a localization. So you need to ask yourself which part of the nervous system is involved. So in Guillain-Barré syndrome, what is involved is the peripheral nerves. So meaning that when someone has symptoms or they have weakness, it will mostly be weakness in the distal part. So they'll be weak in their feet, they'll be weak in their hands. They'll have an ascending weakness, and usually that weakness will be quite acute and it will be progressive. Usually in GBS, even though it's not always, you most often have sensory symptoms. So myasthenia gravis, when we think about its localization, for it's in the muscle. So it's different from GBS. And when we say it's in the muscle, it's not just in the muscle, but it's in that communication between the nerve and the muscle, what we call the neuromuscular junction. So myasthenia gravis is more like a chronic autoimmune disorder. So if you think about things like lupus, if you think about things like Graves' disease, it's in that same way that you would think about myasthenia gravis. So it's more chronic. The symptoms will often come on gradually and they tend to fluctuate. So you have fatigable weakness, as Dr. Mutale described, where sometimes you feel better, sometimes you feel weak. In GBS, it will be quite acute. The symptoms start within 2 weeks. You're just getting worse and worse. In some cases of a myasthenia emergency, they can present quite acutely as well, but the pattern of the weakness is different. They will be weaker more in the shoulders and around the hips, whereas in GBS, to be more in the feet and in the hands. When you hear things like double vision or drooping of the eyelids, again, that is very common in myasthenia gravis compared to GBS. So it really starts with seeing some of those key features. So for me, I think the key things would be if they have fatigable weakness, the weakness fluctuates. If their weakness is more proximal than distal, if they only have weakness and they don't have sensory symptoms, then I would think that that sounds more like myasthenia gravis than like GBS, though it can be difficult sometimes. All right, I don't know if anyone else wants to add. Thanks.
Thank you so much, Dr. Stella, for that. Can I just get confirmation that Dr. Zimba and Dr. Chilando are on the call? Okay. So well, as we wait for their confirmation, I think we'll proceed to the next question. Thank you so much for that great clarification, Dr. Skele. So the next question comes from Ihewa Gaula. I hope I pronounced that correctly. And they ask, why do they worsen MG, and why do the medications such as antibiotics worsen MG?
Yeah, I think that is probably, I'm guessing, the same question. So the question is, yeah, why are there certain medicines that make myasthenia gravis worse? Although the answer is not clearly stated to say it's because specifically it does this and this, but those medications are thought to interfere with the function of the neuromuscular junction. So to some degree, like the macrolides, the fluoroquinolones, they cause some disruption in communication between the nerve and the muscle. So in people who don't have myasthenia gravis, this is not a problem. They can cause some problem, but if you don't have myasthenia, that gets overridden. When you've got myasthenia gravis, if you think about it, it's that you've got something sending a signal, and then you've got the muscle which receives the signal. So it has little satellites. In myasthenia gravis, a lot of those satellites have died. So it's working under very limited capacity. Now, if you add on something that disrupts that capacity, then it makes them worse. So that is the thought behind why these different drugs make them worse. It's that from the mechanism of the way the drugs work, they are thought to affect the neuromuscular junction, but in someone who's already susceptible, like they have myasthenia, that can make them worse.
Okay, thank you so much. And there's a thank you remark from the person who had sent the question, Gaula. So the next question comes from Matthews Gumbo, and his question reads as follows. What's the goal towards the disease while treating with pyridostigmine only, since it's not disease altering?
Thanks. Okay, so I guess I'll take it again since I'm the only panel of experts.
Yes. Yeah.
All right. Thanks so much. Yeah, so again, I think Dr. Amtale did a really good job taking us through our goals of treatment with myasthenia. When we think about when we're treating myasthenia, there are two things we're doing. So one is we're making the symptoms better, and two, we are trying to control the pathophysiology or what is causing the disease to start with. So if you think about it, if someone has headaches, for example, you can give them Panadol to stop the headache, but it doesn't mean that you've stopped what's causing the headache, and so you can then give another medicine as a prevention. So it's just a double approach. So pyridostigmine is symptomatic treatment. So at the time when you're feeling weak, it helps you feel stronger. However, we need medicine to control that abnormal immune system function. And so medicine like prednisolone, medicine like azathioprine, methotrexate, those medicines now go behind the scenes to go to the root cause of what's causing the disease. So you are just approaching it from different angles. And that's why the two drugs are used together. It's also important, I think, one thing that we often do with the medicines for myasthenia is we know that for most people, they need a long duration of medication, sometimes even lifelong. So often when we start them with the prednisolone, for many, within a few weeks, we introduce that steroid-sparing agent because we are trying to prevent the side effects of steroids. So it's just a double approach. You're treating symptoms, like you have a headache, you're giving a painkiller, but then at the same time, if the headache was because of meningitis, you're treating the meningitis. So that's the approach, treating the background problem while you're treating the symptoms.
Okay, that's a brilliant response. Thank you so much. Matthews sends a thank you response to your answer. And lastly, we have another question from Jonathan Cyrus. So for those that haven't asked their questions, if at all you have any question, I think we still have a bit more time on our blog, so you can still send. But the last question as we currently have is from Jonathan Cyrus and Tate, which reads as follows: in children who develop transient neonatal myasthenia gravis, are they at an increased risk of developing myasthenia gravis in the future?
Okay, thank you. So with myasthenia, neonatal myasthenia, this is thought to be a result of just a transient transfer of those antibodies into the baby and then they grow out of them. So whether someone inherits an autoimmune disease or not is very complex. Usually we find that in families, they might commonly have autoimmune disease. So in one family, you might find there's myasthenia, there's rheumatoid arthritis, there's lupus, but there's no way really the genetics or the inheritance is not direct. And again, with neonatal myasthenia, it's simply an osmosis situation, if you will. It's just that some antibodies leaked in there, but they are not changing the genetic makeup of the baby. So in simple terms, that baby has increased risk of developing myasthenia or another autoimmune disease just by virtue of the genetics, but not because they had neonatal myasthenia. There isn't evidence that having neonatal myasthenia gives you myasthenia in future, but having a mother who has myasthenia makes you slightly more at risk than someone whose mother doesn't have it. But it's not a straightforward thing. And so we don't teach or counsel our patients to say, because you have myasthenia, your kids will have it. That's not how it works. But their children do have some increased risk of an autoimmune disease because they have it.
Okay, thank you once again, Dr. Askile, for that. Jonathan, Cyrus, I hope your question has been answered to your satisfaction, but I'd like to believe all questions have been addressed adequately and entirely. So I'd like to believe we have not been joined by the other panel of experts from whom I would have expected further comments or additions to the questions that have been asked, as well as the presentation in general. But yeah, since we do not have those, I'd like to believe we've come to the end of our session. But I'd like to express my sincere gratitude to the didactic presenter, Dr. Mtale, as well as Dr. Melody Asikile, for sparing time to come on board for this session. And most importantly, the audience who make this a success, because I think without the audience, NeuroMed Easy Echo would not be possible. So in summary, for today's session, we discussed myasthenia gravis and neuromuscular junction emergencies. And we had Dr. Mtale run us through the definition of myasthenia gravis as well as neuromuscular junction emergencies. He talked about how these can be diagnosed. He also talked about how we can, he gave us an outline of the acute management priorities and described the monitoring strategies of myasthenia gravis and neuromuscular junctions, and further closed with how to identify indications for transfer and the different bedside tests that we can conduct in order for us to diagnose or have a high index of suspicion for myasthenia gravis in our settings. So this marks the end of our echo session. Thank you once again to everyone for creating time. Have a good day.